Bowel elimination. The gastrointestinal tract, we are going to start back here again. We're an extension really of the nutritional system, and appreciating that the digestive tract is a muscular tube that extends the whole length of the body from mouth to anus. The mouth receives food and prepares it for ingestion and speech. The pharynx is the throat. The esophagus is a 24 centimeter in length tube that carries food from the mouth to the stomach. The stomach has 3 layers of muscle. There's 2 sphincters, the cardiac sphincter at the top and the pyloric sphincter at the bottom. The small intestine is the largest part of the digestive tract. It's about 10 to 13 feet, including the duodenum, then the jejunum, and then the ileum. Most absorption of food takes place in the small intestine by way of the villi. The large intestine has 3 purposes: storage and elimination of waste, the reabsorption of water, and then the synthesis of bacteria. When you think of the large intestine, you can picture the ascending colon, then the transverse colon, the descending colon, then the sigmoid, rectum, and anus. And then finally, there's defecation. Common problems when we're talking about the bowel elimination is constipation. Constipation is a change in the normal bowel movement characterized by a decrease in frequency and/or hard, dry, difficult, sluggish action of the bowels. And usually it's less than 3 bowel movements a week, and that's considered to be they're constipated. Whereas if someone is having an impaction or they're impacted, that's when the stool is tightly wedged. That's kind of the key word, wedged in. It's an overloaded organ, so they're impacted. Often when someone's impacted, liquid stool comes around the impaction, and it would appear they have diarrhea, but when in reality, they don't. It's the liquid around the hard impaction. Diarrhea is frequent in liquid stool. Incontinence is the inability to retain feces. Flatulence is gas. And hemorrhoids are dilated or tortuous veins, or a vein, in the anal rectum. They can be external or internal hemorrhoids, as you can see in the picture. The treatment is good anal hygiene, keeping people clean, stool softeners to prevent straining, anti-inflammatory meds, and maybe even surgery to have a hemorrhoidectomy and have those removed. They can cause bleeding. Usually that's where you see frank blood, bright red blood when someone goes to the bathroom or wipes from the irritation of stool on those hemorrhoids. They complain of them being very painful and itchy, and those are kind of mild looking ones in that picture. They can be really ugly, I guess, best word I can think of at the moment. So things we want to do when we're talking, getting an assessment and trying to understand our clients, and that is get a good nursing history and find out what their elimination pattern is, how often they go, when they go to the bathroom, characteristics of the stool. Is it hard, soft, formed, brown, green? What's going on? Their routines. Do they go every morning and night? No routine. What's going on with them? Do they use medications to go to the bathroom? And I mean to defecate. Do they have to use stool softeners? Do they use fibrous meds like Metamucil or something to help them go, or are they dependent on enemas? Do they have a bowel diversion, like an ostomy? And so instead of the stool going through the anus, the bowel's been diverted to the abdomen and it comes out through an opening in the stomach. Is that diversion temporary or permanent? Have there been any changes in their appetite? Are they eating more or less than they have been? What's their diet like, and are they getting enough fluids in? Because fluids are just seriously the best way to prevent constipation. You need good fluids. Let's see if I have anything else here. No. All right. Prior medical history and use of medications. Some medications, maybe like opioids, they've been taking for pain. If they've been on those for a while, is that why they're constipated? Or is a medication giving them diarrhea? Maybe they've been on antibiotics for a while. So what's going on medicinally? Emotional state. Are they stressed? Stress can cause diarrhea and constipation, but both. What's going on? Depressed. What's their exercise pattern like? Are they active or are they sedentary? That can influence or affect bowel movements. The presence of discomfort. Are they having pain? Pain can slow the bowels down as well and cause constipation or cause diarrhea. Their social history. That's kind of an interesting one, but maybe cultural practices for privacy and that sort of thing. Their mobility and dexterity. Are they able to get to the bathroom in time? Are they able to get their clothes on and off to go to the bathroom? How's that going? There's physical examination that needs to be done. Looking at their mouth and seeing how they are doing with their ability to chew their foods. A good abdominal assessment. This is when inspection is so important to see if somebody's distended. If you can see sometimes the dyssymmetry of the stomach, you can see like a lump in the stomach and it's bowel. Listening to auscultating the bowel sounds to see if they're hyper or hypo. So give a good physical examination. Look at the rectum, the anal area, to see if there's hemorrhoids, if there's bleeding, sores, fissures, kind of things at that rectum. Fecal specimens are something that we do to see if there's something going on within the bowel that's giving the client difficulty. And one of the fecal type specimens that we get is called a guaiac, or it's a guaiac to look for hidden blood, maybe called an occult specimen, occult blood, which we're looking for hidden blood, and that blood is called melena. And so we're looking for the blood in the stool. And one of the ways we can do that is through these guaiac, I don't know what you even call them, strips, cards there. I gave you a green and yellow one. People, for example, their insurances after 65 will send them these cards in the mail, and they're supposed to get 3 specimens and send the card back in the mail, and then they get tested. And so if you open the card, like in this top picture, you open the card and there's 2 little squares up there of just white paper. So when the person goes to the bathroom, they have these little applicator sticks, like skinny popsicle sticks, and you get a little piece of stool from one part of the bowel movement and smear it onto that one little square on the front, and then get another part of a specimen from another part of the stool, just a little piece of stool, and smear it on the inside of that card, and then shut the card. Then you turn it over like this second picture down, and you open up the top, and you see that orange piece. You put the developer from that bottle on that orange piece. That's called the control. And if it's blue, that means positive, and if it's white, that's negative. So then you put a drop of the developer up on those 2 squares where the stool specimen was, and if it turns blue, then it's positive, and if it's not blue, then it's negative. The problem is that with the guaiac, it's identifying the presence of blood in the stool by detecting peroxidase activity of the heme molecule in hemoglobin. That's the part of the hemoglobin it's looking for. These tests are not specific for human blood and can produce false positive results when red meat, which contains heme, or fruits and vegetables containing peroxidase are eaten in the days preceding that guaiac test. And then bleeding in the upper GI tract from the use of non-steroidal anti-inflammatory drugs or high doses of vitamin C within days of the testing can cause false negatives. That's kind of tricky. So there's a new test that's been out recently, last 5 years or so, and that's called the fecal immunochemical test, a FIT test. And it's a newer fecal occult blood test that has a higher sensitivity and specificity for the detection of adenomas and cancers. That's what they're looking for, cancers in the bowel. And they're just more accurate than the guaiac-based test because they use antibodies specific to the human globin to detect globin in the stool. Therefore, the FIT test can be performed without dietary or medication restrictions like that guaiac-based test. In addition, that FIT test is highly specific for detecting lower GI bleeding, but not upper GI bleeding, because the globin is largely degraded by upper GI enzymes. All right, the key here is the FIT test, you don't have to wait to eliminate meds or make diet changes. And another great thing about this test is you only need one sample, whereas before, if you're looking up at that top picture, you needed 3 samples to determine blood in the stool. So it's a much simpler and more accurate test. There are other fecal specimen tests that we get looking for parasites, for example, and whenever you do a test that you're looking for parasites, it will call it an O and P, ova, the egg, and the parasite. And when you get an O and P test, you need to make sure that that specimen is not refrigerated. You want to keep the parasite alive. And there you go. So checking for those stool specimens, usually, I don't know, a couple tablespoons. Someone will say a walnut size is about how much you need, but you can always double check with the lab for how much they need. Anyone that they're suspicious, they've had recent diarrhea, they've been on antibiotics, and they're trying to rule out C. diff, Clostridium difficile, that would be another type of fecal specimen. There's different diagnostic examinations that are done for the bowel. I'm thinking of a colonoscopy where under sedation, the client gives consent and they're under light sedation to look up into the bowel, looking for polyps, cancers, anything going on in the bowel. So there's a number of different examinations to check on people. And then always check with the client. What's their report? What are their expectations for medical care and their involvement in their care? A couple things I just wanted to go over with us, and that's just basically diarrhea and constipation, what it is, and ways that we can treat diarrhea. So what are some causes of diarrhea? If I was in class right now, I'd pause and see if you guys could come up with the 10 things. 10 I have on my little list here. 10. Can you think of some things that cause diarrhea? All right. Well, we can't wait forever on an audio tape, right? So let's go here. How about spicy foods can cause diarrhea? How about an impaction? Remember that liquid stool coming around. It appears they have diarrhea where in reality they're impacted. Bacteria like E. coli, Salmonella, Clostridium difficile, a spore. Toxins, drugs and medications. Laxative abuse, malabsorption syndrome, like celiac disease, stress, bowel tumors, irritable bowel syndrome. All of those things might cause diarrhea. There are non-pharmacological measures when someone has diarrhea that we're going to do, and probably the first and most obvious is fluids. People need to replace the fluids that they're losing because diarrhea is, those intestinal fluids are rich in sodium, potassium, bicarb, water, and so diarrhea can cause mild or severe dehydration or electrolyte imbalance. So rehydrating people with not just water, but good old chicken soup, Gatorade, something that's going to replenish some of those electrolytes. Traveler's diarrhea is often caused by Escherichia coli, E. coli, and so ways to prevent that diarrhea is to drink bottled water on a trip, wash or avoid fruit, and cook all vegetables and meat. And remember, diarrhea can break down skin, so you really need to help the client protect their perianal rectal area. And you can do that with simply Vaseline, A&D ointment, Decidin, anything to put a protective barrier on their anal area. Causes of constipation. Oh, I have, let's see, 8 here. Can you think of at least 8? Actually, I have 10. 10 things. The number 1 cause, insufficient water. I was pausing on purpose. See if you could think of it. Not enough water. Water is the best relief of constipation. Poor diet habits can cause constipation. Fecal impaction, bowel obstruction, chronic laxative use, neuro disorder, ignoring the urge to defecate. Like, oh, you're out camping and you just won't go out camping or on vacation or in public or whatever, putting off the urge to go. Lack of exercise. Exercise is so important to maintaining peristalsis and keeping the bowels moving. Medications, especially anticholinergic meds. Hypocalcemia. All of those things can cause constipation. Some non-pharmacological measures. Number 1, water. You got it, water. Dietary fiber, exercise, routine bowel habits are all things that we can do to help people have normal bowel movements. Normal is considered a bowel movement 1 to 3 times per day. That's kind of normal. Some people go more than once a day and some once. I mean, very few go every other day as a routine. But anyways, that's the kind of the average normal. Fruit juice can also help. And again, it's a liquid component, but that can help with getting more fluids into the system. Some pharmacological relief can be through laxatives, cathartics, and purgatives. And laxatives are considered stool softeners. They promote soft stool. Cathartics are stimulants, and they can help soften stool, but can result in some watery stool and crampy bowels. Complaints of that. Purgatives are a harsher cathartic, and the dosage of the med determines its class, whether it's cathartic or purgative. Types of laxatives would be osmotic laxatives. Osmotic laxatives are saline oriented. There's higher salt, so they draw water into the bowel, and that helps soften stool. Stimulants are contact oriented in that they help increase and stimulate bowel activity. Bulk forming often are like fibrous type meds, like Metamucil, something that adds fiber or bulk to stool to help it evacuate better. Emollients or stool softeners are all in that laxative category, and would help relieve constipation. Things you can do to help restore bowel function is bowel training, having people go at the same time every day, eating the same foods, maybe trying a glycerin suppository till things just get regulated. Maintaining proper fluid and food intake, keeping track of the volume that they're really taking in. Promoting regular exercise and simple as walking, being active, just moving, parking further at the grocery store, different things to help people get regular exercise. Good hemorrhoid care, good medications, avoiding straining, those kinds of things will help restore regular bowel movement, and then also maintaining skin integrity. All right, well, if you have any questions on that content, bring it to class, and we're going to continue looking at the bowels, looking at ostomies and care planning and such for the client.